Good afternoon. It is basically for the extra-articular proximal tibia fractures wherein we wish to do nailings. There is an option, we can do plates also, it's not bad, but nailings can be done. In the proximal, too high fractures, what is the problem? It is the malreduction. It's a concept which is a consequence of surgical technique many a times. A valgus in the coronal plane and a flexion in the sagittal plane. The flexion is because of the extension of the proximal fragment which is pulled by the patellar tendon, and a posterior translation of the distal fragment. Entry is the most important in all these fractures. If you are doing a nailing, the entry cannot be lower down. If it is lower down like this, it is going to go and towards the posterior cortex. So it has to be high enough. Now look at this entry point. This is a little bit medial. And mind you, if you cannot do this, you have to always centralize the nail in the proximal fragment. Wherever you are doing a periarticular nailings, you have to centralize the nail in that periarticular fragment. In this way, if at all the nail is going from here, you add a small polar screw so that the nail is centralized. As well as in this position also the nail should be centralized. Now look at this. This is a more medial entry point, and if you again a polar screw addition on the concavity of the fracture or wherever there is a combination. And here again, if your guide wire is tending to go more posteriorly, add a posterior mediolateral polar screw so that your guide wire is parallel to the anterior cortex. You have to have your guide wire parallel to the anterior cortex and in the center of the proximal fragment. Herzog's bend. It cannot be in the distal fragment as over here. You will have a malreduction. The Herzog's bend should be in the proximal fragment. Technical errors many a times of the nail designs, we use uniplanar fixations. You have to have oblique locking screws. One proximal screw is not sufficient if you are doing extreme nailings. Herzog's bend cannot be in the lower part of the fracture. It has to be in the proximal part of the fracture. The solutions are what? The old entry should be given away. There should be a new entry point. These are the dimensions exactly whatever said. But you can always remember that the entry point should be slightly lateral to the midline. It is ideally just medial to the lateral tibial spine. The safe zone, Paul Tornetta is a big man in USA and he has described all these things, especially nailings in proximal tibia. Parallel to the anterior cortex. These two things you should remember. Entry point should be just lateral to the medial tibial spine and parallel to the anterior cortex. Now, this is very important because AP width of the medial tibial condyle is narrower on the medial side than on the lateral side if you see end on. So that means your lateral tibial condyle is in collinear with the intramedullary canal. So if you enter from the medial side, which is narrower, and if you put your nail, it is going to go laterally and it will cause a valgus deformity. So whenever you enter slightly lateral to the midline, and that's the high entry point. What Paul Tornetta is recommending, and I have been practicing that for all these proximal tibia nailings, it is very easy to have a semi-extended position, knee flexed only in around 15 to 20 degrees of flexion. A parapatellar arthrotomy. Now, arthrotomy is a big thing for us if you are doing nailing. It is not a big thing if you are doing a TKR. But arthrotomy can easily be done over here. You can see end on with your with your eyes on vision and retract the patellar tendon. Retraction of the patellar tendon will neutralize the forces of the patellar tendon on the proximal fragment, and it will be easy for you to nail. And that's the thing. Look at this picture. That's a two-step entry point which Tornetta has described. It has been shown that in 69% of the knees, That's a ligamentum transversum which connects the anterior horns of the medial and lateral menisci. Now, if you're doing a blind entry point, for these fractures, a suprapatellar entry point also has been described, which is a blind thing. If you're doing a blind entry point, you will never know what you're disturbing. The ligaments or the transversal ligaments, and that's a specific cause of anterior knee pains, post nailings, these high entry point anterior nailings. If you open the joint, two things you achieve. You achieve your patella goes, retracts, it falls away and it neutralizes the forces on the proximal fragment. You can easily do it in the supine position. Your patella will not come in the way of the jig. You can easily place your jig over there and you can go parallel to the anterior cortex. That's what is required. That's a two-step entry point which Tonetta has described, and you have to be somewhere over there while entering. And look, entry point from the medial side, which is slightly narrower, you cannot have, you can have to have, this is the collinear with this intramedullary axis. That's a two-step entry point, and you have to be always there, superior entry point. That's the entry point. If you have to have, you can have a blocking screw or polar screw posteriorly. Tonetta describes it in the semi-extended open medial parapatellar arthrotomy by using the extended incision hyperflexion, that is 90 degrees of knee is not required, that is what Tonetta says. Semi-extended 15 degrees parapatellar arthrotomy, and this reduces the anterior angulatory forces, and that's the position, more supine and no hyperflexion at the knee joint. And I would like to show you a small video over here, which I have done. This is basically all these points one has to remember for. No, I'm going to the folder. Yeah. It'll come. This is the particular. This is a high entry point. Oh, it will not come. Then forget it. Okay. Sorry. Let's forget the video, we'll go ahead. Concluding in this particular, the proximal tibia nailing, I would like to say that the incision has to be made after reduction and should be high. Do not hesitate to do an arthrotomy. The nail will never reduce your fracture. You have to get a reduction first and then pass the nail. Enter from the safe zone of Tonetta, which I have shown you. More proximal entry point just anterior to the articular cartilage. Use of polar screws for all proximal fractures is necessary. Herzog's bend preferably has to be inside the proximal fragment. In fact, if you are going more higher up, intra-articular entry point, Herzog's bend is ideally not required for such nailings. I remember Professor Ulrich Holz telling that in fact he straightens the nail and removes the Herzog's bend and puts a straight nail. Herzog's bend is meant for a lower down tibial tuberosity entry point where you have to go more posteriorly and then down. A correct entry solves all the problems of proximal tibia nailing. Now I go to the distal, which is an extreme nailing. Oblique distal third tibia fractures. Difficult to treat, rotationally unstable, obliquity, or lower down, two lower down fractures. Then soft tissues dictate the method. There's less space for fixation or getting your interlocking screws. The principles are reduction, maintain it, rotational stability, and polar screws. Again, polar screw placements you have to know. Indications are all the low velocity injuries, closed injuries, distal metaphyseal, extra-articular preferably. If it is intra-articular, you need to get an intra-articular congruity first. Syndesmotic congruity is important. Nailing in the distal third is its advantage is over a mapo plate. There is no soft tissue dissection, but requires proper size nail. Just half a minute. But requires a proper size nail. Must do a CT scan to treat your intra-articular extensions. Polar screws are must. Plan with X-rays, with CT scans. Use nails with at least 3 locking screws in the distal fragment. At least 3, AP, lateral and oblique. You get such nails. Tips are, use a guide wire and keep it as central as possible. Again, centralization in the distal fragment is very important. Use a distractor for reduction. Keep LCPs ready if you cannot do a good nailing. That's the way. This is the typical expert nail that you can use in these fractures. tips are that get your intra-articular reduction. First is intra-articular reduction. Here the intra-articular reduction is achieved and then go ahead for nailing. If at all, sorry. The polar screws, if there is a varus deformity, the proximal screw should be more medially and the distal screw more laterally placed. And then you can correct your varus deformity in this way. Look, this particular patient had got a slight varus deformity and we have put the screw more laterally and you have got a good reduction. Centralization of the nail is important. Then, if you have a valgus deformity in the distal fragment, ideally this is not the situation, but you may put your polar screws wherever you want, but centralization of the nail and correction of the deformity, getting a good alignment is very important. This is the way you place your polar screws and that's the way we had done it. Or, polar screws may be placed alternatively, medially and laterally to centralize your nail. But that is very important. Once you do that, there you get a good reduction, and alignment, reduction is very important. Again, this is a segmental fracture, their polar screws have been placed. Concluding, I would like to say that distal third oblique tibia fractures can be treated with intramedullary nailings. There are extreme indications for nailings, but you will have to get multiple, multi-level and multi-directional locking screws in that particular fragment to get a good